Okay, I show you cases. I thought this could be interactive, but I heard that nobody can really answer questions, so I show you the question, you think about it, and you tell me. You can decide yourself if you were right or not. So the first case is a 27-year-old healthy mom, G1, P0, referred for SVT after having been started on treatment with sotalol, and there was no improvement. I show you the tracings. I go back to it, don't worry. It's not that I leave you without any explanations, just show the images. So atrial ventricular rate up here. And then the baby does this. And this is the tracing. So in M mode, so what is the underlying cardiac rhythm? Are my colleagues okay to treat that one? Is this atrial flutter? Is it AV renal tachycardia? Is this sinus brady with an accelerated junctional escape rhythm? Or ventricular tachycardia? I'll show you the tracings one more time. So this is the first rhythm I showed you. Ventricular rate 136, atrial rate 129. So for a 22-weeker, the atrial rate is a bit on the slower side, but not completely out. But if you look very carefully, your ventricular events are not happening in coordination with the atrial events, right? And you have more ventricular beats than atrial beats. So in a way, the diagnosis of a sinus bradycardia with an accelerated ventricular rhythm is not wrong for that one slide. But, so I'll show you this, there's no relationship. But this looks obviously a bit different because the tracing I showed you, there was a fast heart rate that was quite irregular with slowing down and speeding up. So what's happening here? It's ventricular tachycardia, right? Or junctional tachycardia, I can't tell the difference. There's one break here. So the atrial ventricular rate much faster than the atrial rate, which is completely irregular, because the atrium has no clue what's happening in the ventricle. So I showed that before. So you have to decide what you make out of this. Is this no idea whatsoever? To the rest of the pregnancy, long QT, bradycardia, yes, was a bit slower. Is it inflammation or are they cardiac tumors? I'll show you the ventricle, the myocardium one more time. Do you think that's a completely normal looking heart? So if you look very carefully, the papillary muscle look brighter. At least that could give you an idea that there could be an inflammation. Actually, they're bright, the papillary muscle, and if you look very carefully, the AV node might also be a little bit brighter than that should be. So we tested the moms for anti-Ro antibodies, and sure enough, they came back high positive. So we started treatment with dexamethasone and IVIG to stop the inflammation of the heart, and discontinued sotalol, which was not the right thing to use anyway. So this is 8 days on dexamethasone, and we gave one dose of IVIG, 1 gram per kilogram. So obviously the arrhythmia has completely changed from being too fast to being slow. Okay, what do you think most likely has happened? I'll show you. Yeah, so complete heart block. And it's not the first time I see a fetus coming with VT that has complete heart block as underlying rhythm. because it's related to not only damaging the AV node, but myocarditis, frank carditis. So obviously we answered the question already. It's complete heart block, and I label it. I did not show you a nice tracing on purpose, but you can still pick up that the atrial events are clearly not at the correct spot throughout, and the ventricular rate is very irregular. And the atrial events, when you see them, because they're buried within the QRS, you don't see it, or within the V wave, so you don't see it. So it's complete heart block. I just would like to bring this up a little bit, because many people think anti-Rho antibody-mediated heart disease affects the AV conduction system. It does far more. You need high titers, and this mom had both high Rho 60 and Rho 52 titers. It causes inflammation of the heart by about 16 weeks. Most commonly have conduction tissue disease and complete heart block as most common, but also sinus node dysfunction. This one actually had, in the end, a sinus rhythm of 90 beats per minute. So clearly, the sinus node was affected too. Then you can have acute inflammation, you get carditis with reduced function. I always had good function, but the arrhythmia is a manifestation of this, and you can get endocardial fibroelastosis, permanent damage of the myocardium due to scar tissue. This is one just telling you it's not always this obvious damage of the myocardium. Histology, you find far more than you detect by echocardiography. We know that from series that underwent autopsy, but this is extensive endocardial fibroelastosis. Brightness, you see the papillary muscle, the AV node, the walls, and the slow rate. And there's an autopsy on this one, and you see the calcification on the X-ray, the post-mortem X-ray. This is completely destroyed tissue myocardial cells that are now calcified. There are no viable cardiomyocytes seen, and you see the calcifications also here. So some of these patients can have a very severe manifestation of the myocardium, and that's the reason why I wanted to show you this. We treat these patients anyway, not because I think the heart block will go away. Really, actually it improves, but most of the time it doesn't change, but because we want to avoid carditis and long-term consequences of ongoing inflammation of the myocardium with a need of requiring transplants later in life. We published, I got heavily criticized initially, and I didn't invest this to start. Dexamethasone was the rheumatologist who recommended this. But we published this early on, and we were told we are nuts. But frankly, it works. The survival rate is still, in a multi-center study, in a range where you don't see this if you don't use steroids to stop the inflammation. The problem is if we see damage of the myocardium, it's usually too late because it has happened. So we try to limit it. Our patient actually was born. The one I just showed you was born 4 weeks ago and required a pacemaker and is doing fine. So no more VT after this. The second case, which I asked Alfred that I'm allowed to show it and not stop me here, is the 38-year-old mother, G4P3 at 21 and 6 weeks, referred for fetal bradycardia, known since 12 weeks. Wasn't followed in Toronto, but in Winnipeg, and they moved to Toronto. The parents are consanguineous, and this is what you see here. So heart rate between 75 and 85, and this is the Doppler LV inflow and outflow Doppler, and I added some stupid question for you, but it's okay. But I show you more images here. So that's the flow of this baby from the umbilical cord, and here the ductus venosus flow. So what is the mechanism of the bradycardia? Slow atrial rhythm, atrial bigeminy, 2-to-1 block, complete heart block. I showed this to you. So this is an inflow-outflow Doppler. And there are two waves, but one is the passive filling of the ventricle, and this is contraction. But look how short the AV interval is from until the ventricle contracts. 93 milliseconds is extremely short. So usually about 110, 120 milliseconds. And you get actually flow reversal in the ductus venosus again, because the atrium contracts almost simultaneously with the ventricle. That's why you get flow reversal. But it's a nice example how you can see atrial contraction again. So this is a slow atrial rhythm. It's probably not sinus because of the short PR interval. I thought it's atrial bradycardia. Oops. So there are a number of reasons for that. You have a slow sinus node that fires, that doesn't fire appropriately, and either it's the sinus node or an atrial beat that takes over. Reasons for that could be hypoxia. Almost certainly this doesn't have it, this fetus, because it has no brain-sparing signs. Maternal antibodies, they can do everything. That is bad. This one does not have maternal antibodies. Then channelopathy, like long QT, can cause a slow rhythm, and Bettina will talk about this tomorrow. It's obviously also not this. And then left isomerism. Now, I showed you on the picture an interrupted IVC. I didn't see it, but you didn't see an IVC. This baby is not this one, but you see this azygous vein drainage. And this is related because left isomerism has two left atria. There's no sinus node. So that's the reason why they are slower. 40% of these patients are usually in this range. Our patient is slower. So there are other things. So the interrupted IVC I mentioned. This fetus had also a dilated ascending aorta, which sometimes you see in bradyarrhythmia. So most complete heart block babies have dilated ascending aorta, but not at this heart rate. So I thought it's probably a bicuspid aortic valve that I'm missing here, because it's too small. But then there's other things. So this is at 28 weeks and 35 weeks. And looking at the heart's function doesn't seem bad, but something is again not right. Now, again, I gave you some stupid questions here, but one of them is correct, and it's the myocardium that doesn't look normal. Look at this. So it's not ventricle inversion, because this is actually, this AV valve is closer to the apex, so that's the right ventricle. But it looks like it could be a right ventricle because it looks hypertrophied in the apex, and in fact, it's spongy. It's a spongy myocardium. It's non-compaction. Ventricle non-compaction means abnormal thinning of the apical wall of the ventricle on both sides. And you see also in short axis, this looks like a sponge. Now, that's the real answer is the spongy myocardium. And the baby is born, has a low atrial rhythm at 75 beats per minute. And again, the PR interval is extremely short. So exactly what I've seen before birth, confirmed after birth. Now, this is at one day of life. And clearly, it's much easier to see spongy myocardium after birth than before birth. Very obvious. Very thin myocardium and non-compacted, also on the right side. And the aortic valve is trileaflet. Not what I thought bicuspid, but clearly dilated ascending aorta. Now, there's a family history I didn't tell you, and I knew that a little bit earlier. So the dad has bradycardia and non-compaction, and so do three brothers. They have all manifestation. One of them actually had also pulmonary stenosis, and they all have dilated ascending aorta. So what to do with that? I frankly haven't seen that before. Her 10-year-old brother, by the way, showing here, exactly the same pattern. None of them has sudden cardiac death in the family. Sinus rhythm at 48 beats per minute. I spoke with Bettina at that time, I know, and she had another funky cases, pretty much the same, and I found that in the literature. HCN4 channel mutation. There's one amino acid replaced with another one, heterogeneous, and it changes the flow of ions across the HCN4 channels. And what it does actually is it delays the spontaneous depolarization. So the spontaneous heart rhythm gets slower. So it slows it down. How it comes then to non-compaction, I don't know, it is not understood. But this is, has been now reported by several. This is the family pattern of this by Milano, reported LV non-compaction bradycardia. And this one actually also reported dilated AS aorta, as we see in our family. Now, in our family, we were not able to confirm an HCN4 genetic abnormality. And we have run the whole panel because I'm sure this is genetic. It can't be something different, but we did not identify that mutation. But Bettina's case, I think, has confirmed this. So I don't know how we get the diagnosis, but I'm sure this is genetic, and the HCN4 makes much sense. So thank you. Just occasionally we're still puzzled by what we don't know, right? Thank you.